a lot of people are going to doctors and they're getting, I think, Celebrex, and there's a few others out there. Can you just give me your thoughts on pain medication for back pain, and is that ever necessary, and what's that really doing to the body?
Well, I'm really not qualified to talk about meds, but I can certainly give you my own opinions on them.
Okay.
Celebrex may help some arthritic conditions. There's no question about that. But for the more common causes of back pain, again, there are better, shall we say, physical methods.
Right.
And our job is to get the people off their meds.
Okay. Fair enough. That sounds good.
I can think of the example, you didn't mention methocarbamol, which is a muscle relaxant. And so many docs give muscle relaxants for back pain. The best muscle relaxant is posture change. If a person is bent over and in a flexion antalgia because of their back pain, no amount of muscle relaxant will shut the muscle off. But if you can get them to change their posture, they can shut their muscle off, and they'll say, oh, you know, you're absolutely magical. You just took my muscle cramps away. That was through changing their posture so they didn't have to support their back against the loads of gravity.
That's a great point. Now my next question is another question that I think that the general population is maybe misled, or they have a bad understanding of how everything works. When they go to get an MRI and they're given feedback on their MRI, would you say that's a good indication of their current situation of the spine, the discs, the nerves, etc.? And what can an MRI really give you in terms of feedback of where your spine health is?
Okay, well, I think there's two questions in there. Generally speaking, most people would be better off without an MRI, and some people would say that's irresponsible. However, the picture of the anatomy very rarely helps. You will have some docs who say, well, I can't see anything on the MRI, therefore your pain is not real, or I don't understand it, and it must be in your head, go away. Or they will look at the next MRI and it looks absolutely awful, all kinds of things that could be possible pain candidates, and yet the person doesn't have much pain. But here's the concept that would help people understand. As you age, there's no question the discs will slowly dry out, lose water content, and flatten. Right. Say a person did damage one of their discs or their vertebra with, say they had an end plate fracture during a lifting injury. So that joint is now flattened. Over the next 10 years, they will have a load intolerance. When they have poor form when they lift, they'll increase their back pain. When they sit too much, they'll increase their back pain, etc. But after about 10 years, their pain will start to go away. And yet, the MRI through this whole 10-year period has looked worse and worse and worse. First, it shows a flat disc. Then it shows sclerotic bone growth. Then it shows arthritic spurs are starting to grow around that unstable segment. Then the facets start to atrophy and glow on the MRI, et cetera, et cetera, et cetera. So after 10 years, it's a terrible-looking MRI, and yet the term we use is the pain has burned out. After 10 years, the arthritis has fused up the joint naturally. There's no more motion left in the joint. The bone spurs have grown over the whole thing. So as I said, the bad news is that the MRI looks awful, but the
Right.
joint has now stabilized. Guess what happened to their pain? It's all gone. So that's why the MRI doesn't correlate with the pain. Now, if you're going to have surgery, the surgeon needs to know what he's going to cut out or alter to try and change the pain generator. That's when the MRI is used. So once the person has been identified as a really good risk and a high probability of a favorable surgical outcome, then has the MRI to guide the surgeon what he may have to go around, what he may have to really alter. But again, his risk versus reward, the reward increases when there's just one thing that the surgeon knows that he can go in and alter. But if there's more than one, you're now really rolling the dice and just hoping that he gets the one that's the major pain cause. But anyway, that may help people interpret their MRIs. And one other thing that I've written a lot about in my books, and I chide the radiological community for, is the radiologists never see the patient. So when they see the MRs, they look at some peculiarities and just state what the peculiarities are. But who's the person that makes the links between the MRI findings and the actual patient? That's
right.
It's not the radiologist, because they never see the patient. So there's a missing link in the whole medical process to really obtain the information. So I ask every patient who I see, they have to bring their full set of medical images. I never look at the images until I examine them. And then from the results of my exam, where I've already identified motions, postures, and loads and tissues that are all pain generator candidates, then I look at the MRI and say, well, that makes sense. There's edema in that bone. That's a bone bruise. That is accounting for why they can't tolerate compression. Or